Hey guys, you're watching the Best Practices Show, where we take a look at the best business practices from the best dental practices all across the country. And I've got a crazy special edition today. One of my favorite instructors of all time, Dr. Bencker from the Pankey Institute, where a lot of my journey started. And today we're going to be talking about what occlusion has meant to him and all of his students over all of these years. So do me a favor, grab a pen and hit the share button. We'll see you in a second. Hey guys, welcome back to the Best Practices Show. Thank you so much for watching. Again, having so much fun doing this. Over 16,000 followers, 250,000 views a week, and now 16,000 of you have found us on iTunes. So thank you for sharing. Thanks for all the feedback. And today I've got a crazy special episode that you do not want to miss. Now, before we jump into it, couple things. We are shooting this live on Facebook, and as we're shooting this, or as we're doing this, and you're watching the live feed, you have a couple questions, add them to the feed, and I will ask Dr. Bencker, the master himself, the questions directly. We'll get the answers straight from him. And even if you're watching this after the live broadcast, if you have questions, add them to the feed, and we'll make sure you get the right answers, because we want you to get the most out of this. Now, it's taken me a long time to get you on the show. It's as it is for all of a lot of my mentors to get them on, and I'm just crazy grateful to spend some time with you. And I'll tell my story about how I met you years ago, like many years ago. I had a group of mentors, and they said, you're going to get some training. And there were two people that were very influential early in that training. One of them was Dr. Peter Dawson, and the other was Dr. Bencker. And they told me to go to a place called the Pankey Institute. And I'm like, I don't even know where that is. And so I had to go. And that particular several-day course, it was you and Dr. Clayton Davis, and it was called Pankey C1, and it transformed the way I think. It was such an incredible time for me in learning, and I said this to you before we went live. I learned so much from you in the classroom, but I learned most in the condos at night, just sitting around talking heart to heart, knee to knee. It was such a transformational experience. So thank you for being on. And if people don't know who Dr. Bencker is, and you've been living under a rock, can you tell them who Dr. Bencker is? Tell us a little bit about your journey and who you are and what you've been doing for all these years.
Well, I'm semi-retired. I've been a teacher for a good part of my life. I had a very nice practice. I'm a prosthodontist, and I mainly took on very difficult perio-prosthetic cases for the first 3/4 of my career. And even when I was teaching at Pankey, I still took on cases. And so I've got a lot of experience. I've got a lot of teaching experience, a lot of practice experience. I have a wonderful family. I have a wife of many, many years, 50-some years. Mm-hmm. My son's a dentist in Atlanta, outstanding dentist. My 2 daughters, one's an artist in Asheville, North Carolina, and the other daughter is a magnificent teacher down here in Miami.
Yeah, well, you've had an incredible career, and you've affected thousands of people in dentistry, the practices in their lives. And so I've got a ton of questions, and I know you have a lot that you always want to share. But I guess you and I were talking about this. I always want to ask you this. Who's learned the most at Pankey?
Well, that's interesting. I certainly believe that I have, for only one main reason, is that I firmly believe that if you teach, you have to know more than the people you teach, and you have to really know the subject. And since I've taught longer than anybody else at Pankey, that's why I would say I've learned the most, because I spent more time in front of the class.
Yeah, and sometimes people think teaching is easy, but it's not. I mean, it's probably a 10-to-1 ratio. For every hour you spend teaching, you spend 10 prepping and getting all the information right, doing the homework, and so it's been incredible. And you're such an incredible teacher. You actually have a textbook now, and we're going to talk about that. It's actually been transcribed in Korean and Polish, right?
Yeah.
It's crazy.
And a couple other languages. Here's a copy of it, and it's occlusal concepts, comprehensive occlusal concepts in clinical practice. Awesome. And it's meant a lot to me because I could put into what I've been teaching. I actually took the slides that I teach from and converted them into the textbook. So people who hear me can also buy the textbook, both the textbook and a digital copy, so that they can follow along and really go back and review the subject matter.
Awesome. 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 Now, so you tell us a little bit about this topic. This is such a hot topic, and it's a very, I love it. Why are you still enthused about occlusion over all these years?
Yes. Well, there's a couple of reasons. Number one, it's somewhat mysterious, the role of occlusion. A lot of people don't pay too much attention to occlusion, but if you do pay attention, you start to realize how it affects almost everything. In the textbook, there's 2 chapters that show very clearly how the role of occlusion, even in periodontal disease, the role of occlusion in aesthetics, and certainly the role of occlusion in how we can function, and especially how we deal with parafunction, right, which has really become the number one topic, as far as I'm concerned, in the area of occlusion.
Okay, can you talk about that too? Because I want you to explain that. What is all of the talk about parafunction?
Yes. Parafunction is what we do when we're not actually masticating or chewing food. So it's what we can do with our teeth and our jaws and our lips and everything, so that it becomes the habits that we deal with. Okay. Most of the time, the parafunction starts as we are youngsters. And what happens is it can lead to bruxing, it can lead to clenching, it can lead to all the things that could actually destroy teeth and bone and make muscles tight and sore. It's the whole aspect of the things that we don't actually chew with. In other words, most people think, well, we have teeth and they're there so we can chew our food. But there's so many other things that they get involved with. And this whole idea of parafunctional activity is the habits that we pick up. Now, the great question is, why do we ever do that? We don't know. Mm-hmm. To this day, we don't actually know why somebody grits their teeth and clenches and does those things. But we know they can be very destructive. Mm-hmm. So what the dentist has to do is figure out what they're doing and how we can reduce the amount of parafunction. We can't stop it. There's no known way to take somebody and actually stop their parafunction. Well, there is. If we drug them up so bad, they would be walking around like a zombie, but that's no way to treat somebody.
Right. Right. Do you see this changing? Is it getting worse over time with the environment, or is it pretty much always been the same in that regard, or what are your thoughts on this?
Well, we don't know, but my thoughts are that looking at skulls from archaeological days, they actually also brux. So it's probably been a thing that we've always done. Could it be getting worse? Yes. I think the stress that we're in everyday life, dealing with all the complexities of our livelihood today, it could be that we are bruxing more. The other thing is that we don't wear our teeth through mastication like we probably used to, because we now have refined foods, and we used to chew the kind of things that would really wear our teeth down, so that now we have our stress to deal with, and that's where our wear is coming from.
Mm-hmm. Yeah, and we're going to jump into that because I want to talk to you about the exam. There's a lot of things, and bite spoon therapy, but With a lot of the trends that you've seen in occlusion, just tell me what you have observed over all these years. So you started the Pankey Institute in 1982. You see all these trends come in and out. Where do you think we are at in this point in time, and what do you anticipate we'll see in the future, as you've looked at all these things come and go?
Well, one thing I think that more and more of us are realizing, there's an important role for bite splint therapy, because it's such a common problem to have some degree of wear and bruxing that almost everyone has to go through a period of time when they are wearing a bite splint to relax the muscles, get the joint healthy again, so that we don't keep on destroying our teeth.
Yeah.
When we know that it doesn't have to be that way, because we see some people that get into their elderly years that have almost no wear in their mouth. And yet others, by the time they're 45 or 50, they've pretty much destroyed their teeth and they need a full reconstruction. So that it's gaining control over that parafunction. Not able to stop it, but controlling it through bite splint therapy. In other words, let them grind on the plastic, not on enamel against enamel.
Right.
That is one of the biggest trends. And the other trend is to say, is there some relationship between sleep disorders and bruxing? And absolutely, there certainly has to be. So that it's becoming a major, major topic.
Yeah, absolutely. And you could also make the argument people are living longer now than ever.
Yes.
So this is an important managing all of these forces and parafunction. And then the enamel, which is the hardest substance in the body, it's all putting, I don't care how great a dentist you are, you've got to manage the fact that people are going to be living longer, and you want the dentistry to last. So I want to get into that. Now, we're getting questions already. Christina asked this question, which is a good one. Dr. Becker, why do some people have an uneven or bad bite and have no signs or symptoms, and some people have a perfect class 1 bite and have tremendous issues? Great question.
Very good. It shows that it's not the bite, really. It's the habit, it's the parafunctional habit that causes the uneven bites. In other words, some people have almost no parafunctional habit, and yet their teeth aren't lined up well, but they don't do anything with them. It's those people who do something with the teeth, whether they're level or uneven. It's the habit that causes the problem. See, we used to think, well, if you had an interference, that would cause the problem. That's really not true. You can have an interference and don't ever touch it, never play with it. And yet you could have perfectly straight teeth and play with them all the time. So it's that parafunctional activity that really determines what's going to be your future.
Yeah.
And the only way to know is to start observing our patients when they're young. We know that in the mixed dentition stage, that's generally where the trauma starts. Probably starts in deciduous teeth, but we say, well, that's just supposed to be part of losing the deciduous teeth. I don't know if that's true or not. That's what I was taught. I never really bought into that. But we do know that when we have this parafunctional problem, we start wearing our teeth down at a young age, especially before the maxillary canines erupt. You see, because then the back teeth are grinding against each other, and they don't have the anterior teeth to separate the back teeth.
Right.
Which I must say happens to be the most important fact in the role of occlusion, is getting the posterior teeth to disglue. And you need some good anterior teeth to do that. So most people think that, the most important thing is your contacts on your posterior teeth. I don't believe that. I believe the most important thing is how good your anterior teeth work as discluders of those back teeth.
Yeah. Great point and great question. Now, another question too, because you're so into the research, you do a lot of education research. Deepak, our friend, asked this question: are there any gender differences that you notice in occlusion where you are aware of, and also differing wear across ethnic groups? Do you see any differences?
I don't think so in ethnic groups, especially in the last 4 years that I've been teaching foreign trained dentists that come over here and spend 2 years with me. I see all the same problems, whether they come from the Middle East or South America or Africa or Korea or United States. That we all have pretty much the same problems. But the difference between male and female, I think, is that the female ends up going to the dentist, in this country anyways, more often. So they're sort of tuned to these occlusal problems more than the male, who just continues to brush away until it's almost too late.
Right.
But I don't know that the male wears their teeth down any faster or more often than the female. The female pays attention to it. The female may end up having pain sooner than the man does. But it's not a big deal because it can happen to anybody.
Right. Well, females pay attention to it, and males pay attention to females and go to the dentist when they're told to, I think. So that's
exactly.
Yeah. Exactly. Now, you were one of the early people that really helped me understand the importance of the comprehensive exam, or the thorough exam. Can you just talk about that? It's all, people try to go around it. They try to speed through it. You try to avoid it. But is there any way to do comprehensive dentistry other than through a thorough exam?
Absolutely not. It's the most important thing. It's the critical thing that any good practice has to develop: the ability to do a reasonable, comprehensive exam and keep a routine follow-up going all the time. Right. Just recently, I've seen 3 different offices that I visited that had some implant cases that they were already putting in the implants in some spaces. They didn't notice that the adjacent teeth had a class 3 mobility. So that they're just missing things in their rush to get some implant dentistry done. And I think we have to slow down on that and make sure that we not only do a comprehensive exam, a thorough one, but periodically, maybe once a year, do a review of that exam, because things change in these mouths that we're dealing with.
Right. Now, I've heard this. Do you agree with this statement? Most dentists could do really good dentistry if they just slowed down. You use the word rush. Do you agree with that? Because obviously, if somebody was a licensed dentist and they took the time, they would have noticed the mobility on that case, right?
Right. No, I agree with that we do have to take our time in doing the exam.
Right.
For another reason that a lot of people don't realize, that the exam is important not only to gather the information that we as dentists have to gather so that we can make a proper diagnosis. The main reason we do an exam is to educate the patient, so that the patient begins to be aware of what their situation is. And only after that can we even begin to talk to them about a treatment plan. Right. So you have to remember that it's educating the patient is our number one goal, and educating the patient so that they understand the results of the examination. Right. If we use complex dental term and the patient is not following what we're saying, they get confused, they lose attention, and then when you go to talk about treatment, they have no basis of why they should say yes, because they didn't really understand what their problem was.
Yeah, absolutely. Because one of the things, now again, this may be jumping way ahead, but the reason for the comprehensive exam, a lot of this, people always want to see great dentistry and how they can get better. And I got a chance to see a lot of that at the Pankey Institute. There's no question. But the one thing you notice if you look very closely, most of what you learn is behavioral. These people, these clinicians, while they're excellent with their hands, they were better at really getting to know people. And Dr. Pankey always had, rules like you want to know a certain number of things about people before you even get a chance to touch them with any instruments or your fingers. It was all about the relationship and the balance that you would have. And that's the stuff that made all of this fun for years. And I mean, I'm sure you enjoyed watching people get better clinically, but you watched when they got better all the way around from a relationship standpoint, all of that.
Sure. I do believe that it's our job, if we want to be a really good dentist, it's our job to, number one, get to know the patient, get to know what their chief concern is, and get to know all the factors that are working for them or against them.
Right.
If you begin to know those three things and you can relate to the patient, then you have a much better chance at getting them to accept treatment.
Right. And as a dental coach or consultant, if you want to call us, I mean, I can just speak from a data standpoint. The highest producers of any dentistry, they all do one thing. It's a thorough exam. You can see consistently. Now, I want to get into occlusal bite splint therapy. Can you talk about that? That's a hot topic. It relates to the occlusion. Tell us what you've learned, what you see, and why this is such a hot topic.
Okay. Well, a lot of people know something about it. I spent a lot of years really developing my thoughts and the way I deal with bite splint therapy. Mm-hmm. It's not the piece of plastic that makes the difference. There's no healing properties to methyl methacrylate. What makes the difference is how it's adjusted. So you start with a bite splint and then you start adjusting it over time. Right. It's that adjustment over time that makes it work. And that could be a week, 2 weeks, 3 weeks, or 6 months if it's a very complex problem. But most of the time it's 3 to 6 weeks of fine-tuned adjustment. And then that bite splint becomes something that they can wear, and it's stable, and it allows us to then move on to whatever the next phase of dentistry is. Mm-hmm. I don't like to think that bite splint therapy is ongoing. If it's something that's going to be ongoing, then that becomes a night guard. That's something that we don't keep adjusting. That's just what they wear at night to protect their teeth and keep the muscles relaxed. But anything you want to figure out that is it going to work in the mouth, I like to test it first with a bite splint. Mm-hmm. Then I test it with provisionals, and then I feel confident putting the finished work in. Mm-hmm. So I really do the work actually 4 times.
Okay.
Bite splint, wax up, provisional, finished work.
Yeah.
By the time I get to the 4th time, I'm pretty sure I've got it right.
Right.
And I might have not gotten it right the first time.
Right.
So that's the way I like to look at my dentistry.
Right. And I think anybody listening to this would totally agree, but some people don't take the time again to do the bite splint therapy. You have a wonderful way. Now, and I'll tell you, here's one of the facts. This is the question I get, so I'm going to throw it to you. How do you explain this to the patient? Like, what, Dr. Becker, I get it, but what do I say to a patient that they would value this and want to do it for the right reasons? Yeah.
Well, there's a couple of things I like to say to the patient. Okay. If you think about, you ever seen your tires on your car wear, especially the front wheels? Mm-hmm. And everybody's seen some wear there. And I said, why do you think that happens? Because they're not riding evenly. Okay. So that's one of the problems. Your teeth aren't riding across each other evenly, and they start to wear. So that's one thing. Another thing to talk about with the patient is bite splint therapy is just like trying to sit at a table that has a rock in it. And everybody sat at a table that you have to reach down and put something underneath one of the legs of the table.
I hate that.
Yeah. So I say, why do you hate that? Mm-hmm. And whatever they say, I build on what they say. Well, it makes me nervous, or I feel uneven. Whatever they say, that for them, that's the reason you need a bite splint. Mm. It's the same thing that makes you upset at a table that rocks.
Yeah.
Now, there's another one you can use. A door that doesn't close evenly.
Mm-hmm.
If you think about the door, it swings. It's like your lower jaw. The door swings. It's got hinges, just like the hinge in our jaw. So the door starts to close. Now, it might get tight just before you close the door. That happens a lot. And people have not known that. They say, well, I got to sort of have to lift up on the door in order for it to close. Mm-hmm. And I say, well, the plunger that goes in to lock it, that's the cusp of your tooth. And if that doesn't hit smoothly, the whole closure of the door is not going to work. The closure of the mouth is not going to work right.
Right.
And as soon as you start talking with plain, everyday items that everybody has run across, they start to understand. Mm-hmm. If you start to use the terms centric relation and parafunction and this and that, they get a glaze over their face because they A, don't want to know about it, and B, they don't understand what you're talking about. Most dentists don't even know what that means, let alone the patient. So use very common terminology, and they begin to understand why is that so important.
Right. I love the way you get us to think about different things. Now, I may have jumped ahead by doing the bite splint therapy, but I want to go back to comprehensive exam because when you watch this, you know occlusion has a big factor in this, and you know a thorough exam is important. But how do I get people to do a thorough exam, okay? Like, because we watch the metrics on this. A lot of younger dentists are watching. So I've got a lot of 32, 33-year-old dentists watching this, and they're watching them late at night. So if they're watching this, they hit, Dr. Becker, I totally understand, but my practice is busy. I've got a lot of my patients coming through hygiene. Where would I even begin to start this so that I could start addressing the occlusal factors? And how do I get people into a comprehensive exam?
Okay, that's a great question. It's probably the most important question. And I have maybe a little bit different answer than you might have or other people might have.
Okay.
First of all, I would say it depends where you are in your practice life. If you're on the newer side, my feeling is you have to build a reputation in your community of excellent examinations, where people, when they hear your name, they know, oh, I've heard that he or she really does a great exam. So if you charge what it's really worth, you're not going to get anybody to say yes. They're just not going to do that.
Right.
So I don't like to say give it away, but I almost have to give it away in the beginning until you get enough patients that are out there talking about the way you do a comprehensive exam. Then, in the second half of your practice career, you can charge what it's really worth, $200-300 for an exam.
Right.
So there's another thing I want to add that you may know this, that my son Dr Bencker does. He calls it a records appointment. A records appointment. So it's the exam, it's the x-rays, it's the study casts, it's all of those things he puts in the one thing. And that makes it more reasonable for the patient because they say, oh, I'm getting this, and this. Right. Where if you just talk about the comprehensive exam, it doesn't sound like it's that great of a deal until they get it done. Once a patient has my exam and they've experienced it, then there's no question in their mind it was worth whatever I want or I think is appropriate to charge.
Right.
So what I'm really trying to say is I don't want the patient to turn it down in the beginning because of a fee.
Right.
I don't want to give it away, but I know I can't charge it in the first, let's just say, first 10 years of practice. I can't charge what it's really worth. Eventually, I will be able to. So that's what I suggest dentists when I go to their office and spend time with them. It's more important to start to build the reputation of doing a great exam. And it's a meaningful exam. It's an exam that the patient talks to other people about. Yeah,
that's awesome. And I don't know if you remember, years ago, you taught me, you can't There's one thought that you can do it on every patient, but if you just have too many patients, you can cherry pick the patients that you want, that maybe have the same core values, would be ideal candidates for this, and you identify that in the morning huddle, and then you had a great way of communicating with the patient in a hygiene exam about the comprehensive oral records. Can you describe that a little bit, because you're a master at this?
Yeah, so that was something I really put together and used myself for many, many, many years. I would make sure in the morning huddle that myself and the hygienist talked just a few minutes about what's going to come up later in the day for Mrs. A.
Right.
So we say, look, you're going to go over the exam. You're going to clean her teeth. You're going to go over some important points. Let's look at her x-rays now. So we say there's 2 or 3 things that we both have to look at. And you're going to mention them first. Then I'm going to come in for the checkup, and I'm going to mention the exact same things that you just said. So it's not that we're piling up on the patient, but it looks like we both know what we're talking about because we both found the same thing.
Right.
And then we say, would you like the opportunity to come back and have a very thorough exam? Because what we did now was a preliminary. Mainly, the hygienist cleans your teeth, but she's very good at finding decay and certain things like that. But would you like the opportunity to come back so that I can spend the necessary time and really help you understand what's going on in your oral condition? And when you do it like that, they almost never say no to that.
Right.
Because you've given them the opportunity.
Right. Yeah, and let me ask you this question too, because I've seen so many of your students, once they've had your training, you go back and you pull charts in their office, like Dr. Frank Graziano or anything. I mean, a lot of these patients are restored. They're restored because they're not looking for crowns. They have a standard of care. And I want to ask you this question. How often do you need to sit down with a human being that you care about and have a really good look? Would you say it's once every 4, 5 years, 3 years? Because really it's your choice as a dentist to determine that interval. What's your learning on that?
I think it depends on the patient's susceptibility.
Okay.
There are patients of mine that I have to see once a year.
Right.
And do a thorough re-eval. There are others that can go 2, 3, 4 years. It depends on how susceptible they are. Everybody's got a different sort of rate of susceptibility, whether it's susceptible to decay or to bruxism or to, different things, periodontal disease. So on each chart, as I do an exam, I predict what I'm going to need to see, but then we check it out. It may go longer than I first thought, or may have to see them more often. It's not one set date for everybody. That's the thing that so many dentists sort of get wrong in the beginning. They treat everybody exactly the same. And how often we see them, what x-rays we're going to need, vary from susceptible to susceptible patients.
Right. Now, let's say I follow your advice. I start talking to my hygienist morning huddle. I'm identifying the right type of people. We're getting them into comprehensive exam. I think I'm doing a comprehensive or thorough records appointment. What should I be looking for? And let's say I haven't been through your training, Dr. Bencker, like when it comes to occlusion, what am I going to want to pay attention to in a comprehensive exam or records appointment that would point to occlusal disease or things that I should learn more about?
Well, besides looking for wear and or mobility, which are the 2 biggest factors, then I want to see how well the teeth are working. In other words, I want to see if they grind around, do their front teeth take over and protect the back teeth? If they don't, then we got a problem.
Right.
I want to see when they close, is it a nice even closure or is there a hit and slide? Because that hit and slide is going to disrupt the muscle activity. But mainly it's looking carefully for wear and or mobility. I want to say that over and over again, wear and or mobility, because see, that's also periodontal condition. So you can't do an occlusal exam if you don't also do a thorough periodontal exam. They're both equally as important.
Right. And then classify a thorough periodontal exam, because again, that always needs a little clarification. What is that?
Yeah, well, that's everything you learned in dental school.
Right.
You got to probe the pocket depths. You got to check out the bleeding points. You got to check out the color of the tissues, the thickness and hardness of the tissue. Everything we know about periodontal disease has to be looked for. There's no mystery to it. Anybody that's graduated dental school knows how to do a thorough exam, right, and knows how to do a thorough periodontal evaluation. And it's only because we forget or we run out of time we start taking shortcuts.
Yeah.
To me, there's no room for shortcuts in quality dentistry.
Yeah, absolutely. And I've learned this so much from all of you. There's no less expensive way than doing something the right way the first time.
Right.
And the more you do up front, the less you have to do later. And you find that to be true when dentistry fails. You can usually pinpoint where it went wrong. So when it comes to all of this and the diagnosis, now you've got the thorough exam. The diagnosis piece is another thing. What do you see? What are some of the trends that you've seen in education and the diagnostic elements? Because once you have the information, that's one piece.
Yeah.
Now you have to do something with the information, right?
Well, also, I would give a plug for all the new modern digital pieces of equipment we can have to help us with just excellent diagnostics.
Right.
The types of X-rays, all the new things. I'm totally a believer in going totally digital. It's more accurate. It's easier. You don't go through all the expansion and contraction problems that we've always had in dentistry. Mm-hmm. The new digital dentistry is absolutely 100% better than what we used to use. Mm-hmm. So I'm not one that holds on to old-fashioned things. If the new thing is better, get it, because it's better. But the trends really are less major reconstructions, more types of dentistry that can be done in smaller pieces, mm-hmm, and not have the patient have to commit to big reconstructions. I mean, that was most of my career, because we didn't have implants, we didn't have great composites. We had golden porcelain is what we had, and that's what we used. And we felt we had to splint everything together. And there were reasons for that. We now know more about occlusion. We now know more about periodontal disease and how to treat it conservatively, so that the treatment today can be much more reasonable. But the difference is we're after more realistic aesthetics.
Right.
We can get our restorations to look absolutely beautiful today, absolutely natural. There should be that none of us could tell which is a crown and which is a natural tooth. That's how good we can be today.
Right.
And that just wasn't there when I came into dentistry.
Right. Now, we talked about this a little bit before we went on. When we're talking about all the diagnosis, you got all this information. A lot of times we end up treating the teeth or the bite. Let's talk about the joint and its role in occlusion, and how you're a big fan of being more cautious when it comes to.
Yes.
Can you explain what that means?
Oh, yes. Still today, we don't know everything we need to know about the joint and its treatment. So that if we have a problem that actually has pain where they say it's hurting right here, doc, and they put their finger right on their joint, I'm going to say I don't know exactly how that's going to go. Mm-hmm. We're going to have to work our way through that kind of a problem. Okay. Whereas if it's muscle, predictable. If it's teeth, predictable. If it's endodontics, it's predictable. Everything's predictable except when there's a joint problem. And in that joint, we have synovial fluid. We have a tricky thing with the disc moving around. We don't actually know, except for trauma, what even caused the problem of I'm sorry, that's my.
Don't even sweat it.
It's even a customer. It's a customer service call. Okay. So anyways, the fact of the matter is, when we have to treat the joint, it's not that predictable, even today. So that I'm going to go carefully. Oh my God.
Don't even sweat it. You get those calls all the time now, don't you? Like,
oh my God, all the time. It's crazy. You want to throw the phone out the window because they just call over and over. And I'm blocking calls all the time, and they still keep coming.
That is hilarious.
Yeah.
Thank you. Goodbye.
Goodbye. Okay, so the fact of the matter is, since joint treatments are going to be not predictable, they may end up predictable, but not from the very beginning. I'm going to go slow. I'm going to be cautious. And I'm going to make sure that the patient understands that it's not a totally predictable nature to this treatment.
Right.
If they think I'm going to treat it like that and it doesn't go like that, now I have a problem. And the patient has a problem, and we start not totally trusting each other. Right. So if the beginning, if they point to that joint with one finger, they don't rub it, that's a muscle. They put that one finger on the joint, I'm going to be very careful, go slowly with it. Probably almost routinely start with bite splint therapy.
Right. And you're bringing up a great point too, because what you're really doing is you're managing expectations up front, correct?
Exactly.
And can you talk about the role of managing expectations in a great restorative dentist career? Like, you have to do that a lot, don't you?
Yeah.
Because you can't just promise the moon.
Oh, no.
You've got to learn really quickly. I'm going to tell the patient what they can expect and what we can expect together.
Yes, and you know where it changes in the beginning of your practice, you think you can be very predictive.
Right.
And then you have something that doesn't go right. And then you have another year later, something else didn't go right. Then you realize, wait a minute, I probably shouldn't promise so much in the beginning. Let's work it through. And again, that's why I say work it through bite splints first, then to do the wax up, then do the provisionals, whatever is needed. And then finally you get the work done. Then that becomes predictable because you've done it actually 3 times already.
Right. Now let's speak to this too, because we talk about expectations. Being a dentist who's really a complete care dentist, who does a lot of great restorative dentistry, there's the potential that you'll attract people with a great reputation through comprehensive exam that have been to other offices before, right? And you say, oh, I can help you. And then you go, oh my goodness, this lady could potentially be a little crazy. And so her problems aren't dental problems. You mentioned this beforehand. I love this. You said, we got to be careful that when we recognize we're enabling a patient's unwanted behavior, it compromises the doctor-patient relationship. Because you've seen this so many times. Talk about that.
Yes. Well, I have seen it. I hopefully haven't seen it too much in my own practice, but it happens in everybody's practice that when we almost fall into a trap where we allow somebody to get away with something that we know they shouldn't be doing. Right. It could be in the way they pay. It's in the way they don't show up or they show up late. And we just, it's okay. We'll keep doing it. And all of a sudden, you've got somebody who's really performing very poorly in your practice. And you probably should have caught it in the beginning. Right. Or at least talk to them about it. But if we enable it, if we allow it to keep happening, we run into a serious problem. And I have seen it in my practice. I've seen it in other practices. Many times when I go into somebody's office, there's 2 or 3 of those patients that it's those 3 patients that give them almost all of their problems. It's like 95% of their patients, everything's great. Right. But there's that 3 patients is what they keep remembering over and over again. And it was their fault in the beginning. They
Right.
should have drawn the line. You've got somebody said it to me one time. You have to draw a line in the sand,
Mm-hmm.
and I'm not going over there. You want me to go over there? You want me to do something that's not exactly right into my practice? And I'm not going to do it. I'm not going to step over that line.
Right.
Yeah.
Right. And I know you're a big fan of the doctor-patient relationship. You hear dentists say this all the time.
Yes.
They give themselves a Christmas present once a year. They pick 3 patients that keep them up late at night and they just set them free. They don't kick them out, but they're just like, I'm going to let them go on to other people's care because it's too much stress on my own body to take care of them.
I can tell you a story. One time I had somebody that I thought was like that because I had worked her up and I did the treatment plan and I presented it. And she didn't seem like she was going to go for it.
Okay.
And so I let it ride. And then 6 months later, we sat down and talked about it again. She still seemed to let it ride. And I was thinking, I need to sit down and talk to her. I think she would be better off with somebody else. And so I did. I sat down and talked, and she said, Dr. Bencker, I didn't know that was so important to you. And as soon as she said that, and we talked, within 2 weeks, we started this big treatment. So what I learned from that is sometimes it's the dentist's fault for not stating the problem so clearly with so much passion that they couldn't help but pick it up. They realized how important it was.
Yeah.
And I was trying to be maybe a little too cool with this patient and just sort of told her what we could do, but I didn't say it was really important that you did this.
Yeah.
And so that's the reverse of that. So I was enabling myself to be doing something that wasn't right.
Yeah, absolutely. Well, it just speaks to your lifelong learning, and that's a critical piece.
Yes.
Those are your, I just want you to, who are your favorite students? Like, can you just sum it up? Give me their top 3 qualities. Like, of all the people you've taught, I mean, thousands of dentists, what would you say are the 3 common denominators of your favorite students you've ever taught?
They listen really well. They know how to talk to people without being, overly strong, but show some passion. So they listen, they have passion, and probably the next thing is they're just really nice people. People that you like being with, you like to talk with, you like kidding around with. They have a sense of humor. Yeah.
Absolutely. I would completely agree. And they're humble. They're just humble, and you enjoy their company. Now, we're going to talk about this in a second, but you're still wildly active. You go to a lot of practices. You do coaching, whether it be on the practice, also even give them coaching clinically. And you and I talked about something that's near and dear to both of our hearts. It's their own health. Now, this is a huge problem. There are some dentists, they sacrifice their own health in serving others' health.
Yes.
And you're a big fan of one very big principle. You have to take care of your health almost more than you take of other people's. Can you just talk about what you've seen over all these years?
Sure. I think that especially as we get into our maybe second or third decade of practice, the first decade, we're young, we're strong like a bull, we can keep going. The next decade, that's when things start to show up. That's when we have to pay as much attention to our own health as our patient's health. So you got to have an exercise program. You have to eat right. You have to get some good sleep. You have to watch your posture. You have to have proper glasses when you're at your treatment suite. All these things become a problem as you get older if you don't watch it. So pay attention to your own health as much as your patients.
Yeah. What did you do? Did you do an hour a day every day? Was it before you started with patients, after patients? Like, how did you stay healthy all those years?
Well, I've always been busy in dentistry. Besides my practice, I was always going to meetings and being chairman of this or chairman of that. So I exercised when I could. So I didn't have a set time that every morning or every night, but I tried to at least do 3 miles a day, either in the morning or at the end of the day. And I loved walking. I loved, when I was younger, I was running and anything, but after I had to quit running, the walking was very important.
Right.
Now, in my life now, the most important thing I do for exercise is Pilates. And I have 2 different gals who do that, and they're also physical therapists. So they help me with my arthritic problems and this and that, and they keep me going.
Yeah.
And if I miss it, I realize I got to get back on the track to just keep everything moving, the joints loose and the muscles active and so forth.
Yeah, absolutely. And you and I know so many people, when you talk about the 3-decade principle, first decade, you're kind of figuring it out. Second decade, you really get into honing your skills and you get better. That's why the 3rd decade of practice, that's the best time of your career. That's where all of it comes together. Your knowledge of your hands, your understanding of people, the materials, predictability. And you and I were talking about, some people are in the worst shape in the best time of their career.
Exactly.
And you want it to be the best shape in the best part of your career.
Right. I agree.
Yeah, because dentistry is inherently stressful. I don't care if you're doing 1 tooth or 10. And it's extra stressful for the people listening to this, because the word shape, translucency, margin, those mean completely different things than just a regular dentist. So this is so cool. Now, I know a lot of people are going to have questions about your book and how to get that. And can you just tell us what's in the book? Like, I know you mentioned that, but what is in the book? And why would I want to get it as a dentist?
The book is got all the factors that you need to know about occlusion, but also how occlusion fits into aesthetics, how occlusion fits into all the aspects of dentistry. And I've added some other authors besides myself. Henry Gremion is in it, and he's the expert on the joint issues. Herb Blumenthal is in it on his knowledge of the muscles. And I have 2 periodontists, Steve Harrell and Martha Nunn, who have really defined the role of occlusion in periodontics and have proven without question with their studies that occlusal trauma affects the success or failure of periodontal treatment. So you've got to have good occlusion in order to also have successful periodontal treatment. Roger Solo has the chapter on bite splint therapy. And then my favorite chapter is Matt Roberts. He's my favorite technician. And he talks about the relationship between the technician and the dentist, how they communicate and how they communicate today with digital factors, which are just incredible. That makes the dentistry so much more fun.
Yeah, and I've got him lined up too. He's been ducking me, but I got him lined up, and he's brilliant. So
he's great. He, my son, and myself go fly fishing often, and that's some of our favorite times. Yeah, plus, he flies his own plane around, so it's unbelievable.
And he's a great person, so that makes it even better. Yeah, so to get the book, you can obviously buy it on Amazon, but if you call the Pankey bookstore, which is 1-800, now some people are listening to this on iTunes, 1-800-472-6539. Talk to the people at the bookstore, they'll give you a discount for the book. Yeah. It's fantastic. And then also I got a question from Christina, where can dentists go to learn about doing a comprehensive exam that you're describing? Can you just answer that question?
Oh yeah, with me it's very simple that the Pankey Institute is the place to go to learn about comprehensive dentistry. Yes, you learn a lot about occlusion, you learn about all aspects of dentistry, and it's put together like building blocks. So you learn from the beginning, you keep going, and you end up with one of the best aesthetics classes you'll ever find. There's no question in my mind that's where I would send anybody who wants to improve their dentistry. Whether they're new at it or very, very experienced, that's the place to go.
Yeah, and if I wanted you to come out and speak to my study club, or if I want you in my office, Erwin, you said just have them call your number, and that's the number. Can you give us that number?
Yeah, 305-582-4626.
It's awesome. And he answers his own phone. It's pretty cool. So
Yes.
awesome, buddy. Well, I am hugely grateful you would spend this time, and I'm going to have you back, and we're going to cover a whole bunch of other subjects because you are truly a master and a great giver in the world that's just transformed so many thousands of lives. So thank you, buddy. I appreciate you being on.
It's been fun. It really has.
Well,
Enjoyed it.
It's only the beginning. You taught me that too. So hold on. We're going to say goodbye to everybody else. I want to just, chat with you about a couple of things, but thank you guys for watching. If you enjoyed this episode, which I hope you did, do me a favor and just hit the share button, share it with your friends. We'd love for you to share the information and keep sending us suggestions, things that you want to see in the Best Practice Show. We'll do our best to put them all together. And until we see you next time, keep watching the Best Practice Show. You guys have a great rest of your day.